Yes, to those in Eastern and Southern and Western Africa, but good afternoon to our colleagues joining us from the Asia Pacific region. Again, my name is Jessica Gorham, and I'm the Regional Emergency GBV Advisor based in Nairobi, and I cover all the countries in Eastern and Southern Africa, along with my teammate Luana de Sousa, who will be facilitating or co-facilitating the French webinar this afternoon, along with our colleague Naomi, who is the Regional Advisor for West and Central Africa. I'm happy to be joined today by Leah Ashley Lipscomb, who is the Regional Advisor for the Asia Pacific region. So she will be helping to co-facilitate the webinar today. And then also part of the facilitation team is Pam Godoy, who I think she introduced herself in the chat. She is also part of the team in the Asia Pacific region. And then my colleague from the MENA region is Alexina Russeri. Just very quickly, if we could remind ourselves to please keep your microphone on mute. And if you have any questions, please do put them in the comment box, in the chat box. And Pam and Alexina will be monitoring that chat. And if they can answer your question immediately, they will do so. If not, they are keeping note of all of the questions that we might have for our presenters. And there will be an opportunity at the end for some of those questions to be presented to our colleagues from both REACH and IRC. And as usual, the recording of this webinar and all resources can be found on our website, and we have, and that's GBVAoR.net. So please do look for us on our website, GBVAoR.net. As I mentioned, this is a weekly webinar series, and it will take place at the same time every week. So you don't have to keep looking for invitations. Next week, we will be coordinating with the World Health Organization, WHO, and looking at the health response, specifically how we can integrate into the health response. And we will also hopefully be joined by some of our colleagues at the Global Health Cluster. And then also we will then present some of the guidance that we have been developing here at global level. So I'm really pleased that today we will be discussing remote assessments. And we have colleagues from IMPACT, which is part of the REACH program, who will be giving a really in-depth look at how we do remote assessments. And then I will present just very briefly some GBV specific guidance about what some of the expectations are for our colleagues who are coordinating GBV subclusters or working groups. Then we will have a short presentation on mapping remote services, or also about remote service or remote programming, which will be presented by IRC, Megan O'Connor from IRC. And then our colleagues, Leah Ashley, will present additional guidance by the AoR, and then we will have times for a brief set of questions. So I know that we hope to, as usual, have the presentation completed, or the webinar will take approximately 1 hour. But because of all of the great and rich information that we are presenting today, it might go a little bit beyond, but we really are trying to manage time, because I know that you have a lot to do today as well. So this is why we are keeping all questions until the end. So without any further delay, I'd like to introduce our first presenter from the REACH initiative, Peggy Henry. If you'd like to start.
Hello, thank you for the introduction, and I hope everybody can hear me okay.
Yes, we can hear you well.
So my name is Peggy Henry. I'm a Senior Research Design and Data Officer with REACH, or REACH Initiative, which is one of the initiatives as part of Impact Initiatives. So I'm going to be presenting today some of our experiences with remote data collection and some of the advice that we can offer. I personally am drawing from experiences working in Afghanistan and Iraq, but also briefly supporting the surge response in response to the cyclone in Mozambique last year, but also drawing from experiences elsewhere. What I'm going to be talking about is specifically introducing you to REACH in case you don't know what we do, talking about remote data collection as a whole, providing two brief examples from where we've done remote data collection in the field, talk a little bit about how to go about planning an assessment, talk about data protection, which is ever more important, especially during remote data collection, give you a few tips, and then also make sure that you can contact us if you have any questions about data collection. So on to the next slide. So some background to REACH in case you don't know us. So we are currently operating or previously operated in about 25 countries with about 90 ongoing projects, although this is always in flux. On the next slide, here are some more information on the kind of activities we do. In summary, we are assessment and information management focused, committed ultimately to improving evidence-based programming and planning in the humanitarian and development world. What you will see when these slides are hopefully shared with you after the presentation, there are some annexes to the presentation slides. These are hidden for now, but you would have links to our websites and a few of our other relevant remote data collection and particularly key informant focused resources. And you do have my email address at the beginning of these slides in case you have any further follow-up questions. So here today, we're specifically going to talk about introducing remote data collection. So on the next slide, remote data collection is simply any data collection collected where you or the enumerator collecting this information is not present in the assessment location. There's a range of different methodologies that you'll already be used to using that can be done remotely, although typically we do them face-to-face. These can include key informant interviews, among other types. Something that's often done and I think is relevant for GBV as a sector is focus group discussions. Now, this is a more challenging methodology to use remotely, although not impossible. So if you do have questions about this, feel free to reach out to us. But today we'll focus on key informants, as this is often more realistic in a remote setting. The way in which we can go about these different data collections remotely do vary, and obviously modern technologies have made this much easier than ever before. We can do phone call interviews, but we can also use face-to-face interviews with people that have traveled from an area that's inaccessible to us. Or we can use other things such as Skype calls or following up on WhatsApp. Or you can go back to sort of submitting paper forms into a box and collecting these later. I think since a lot of people are very interested in knowing about remote data collection because of COVID-19, we're going to be focusing on phone calls and key informant interviews today for some of our recommendations, just because I think this will be most commonly used. So on the next slide, I wanted to present some of the pros and cons of remote data collection applicable at any time. So there are, of course, some clear positives. The simple fact that remote data collection is remote. So this obviously means that you're not constrained on where you collect data. You have a wider access and it is safer for enumerators and sometimes for participants. And there's a lot of efficiency. It can be time efficient, cost efficient, and in some ways analytically efficient. Some of the limitations of remote data collection do include that there's some statistical differences. For instance, you might not be able to generalize your data so well, and you can't necessarily verify your results. And it can just be a bit more complex. It can be challenging to build up trust with participants and convey what you're trying to do. I see a question that's just popped up on analytical efficiency. Indeed, it's not necessarily clear. What we mean by this is time efficiency and cost efficiency are quite clear. Analytically, if you want to know about a given area, such as a village or a community, you, in this case, might only need to interview one key informant, whereas if you were otherwise using a household data collection methodology, you might have to do many more interviews, which then takes more time and more money. Hopefully I'll be able to keep an eye on these questions. If you do miss anything, we'll come back to it. So then on to the next slide. So we wanted to present you some of the examples that we do as Reach. Here you have a sort of image selection of a few of our key outputs, all of which have included some remote data collection, if not all. Specifically, what I'll be talking about today are two examples. One that's from a sort of high-resourced and more experienced project that's been running for several years in Iraq, and one that's just a newer project based in the Sahel region. So firstly, for Iraq, we've been currently and ongoing doing an assessment since 2016, providing post-distribution monitoring of cash and other types of assistance. The data here is collected at a household level, allowing generalizable results that's stratified or comparable at a governorate level using a quantitative approach, so household through a call center. The reasons this was done remotely is mainly that the questions we were asking couldn't really be verified face-to-face, and the geographical spread and the number of people receiving assistance was quite vast. So since there's not a lot of gain by going out to the field and the number of interviews to be done is quite large, it was more efficient to do this remotely. A few things did go very well, and we have been able to benefit from a dedicated team that some of the team members have worked on the project since the beginning in 2016. They've been well trained and they know how to present this assessment and the organization very well. And we also really do benefit from being able to rely on receiving accurate beneficiary lists, which include contact details, which obviously makes calling quite a bit easier. There are, of course, some challenges with this. One of the main challenges was how to build up trust with participants and respondents without having this face-to-face interaction. Moreover, how do we ensure that they understand what we're asking about and who we are as an organization? This was done with careful scripting, practice, training, and gathering advice from other organizations that have done similar assessments, so that we now have a good method that works. And we did also have some statistical challenges, for instance, or logistical statistical challenges. For instance, the contact list that we received was individuals that had received assistance, but we were sampling at a household level. So we had to implement ways to make sure that we weren't duplicating our household sample by interviewing more than one person. This was quite simply mitigated by asking if anyone else in the household had been interviewed recently. It's not foolproof, but it does give us some better level of accuracy. On to the next example. We have an example from the Sahel. We are doing humanitarian situation monitoring of the hard-to-reach areas across the three border region between Mali, Niger, and Burkina Faso. It has been running since November 2019, so comparatively it's a younger project, and it takes a qualitative approach using key informants who have traveled out of their area or have traveled across accessible and inaccessible areas to ultimately be interviewed in an accessible area to talk about the situation and needs in those locations. It was done remotely for a few reasons. but simply that the areas were hard to access. If we can't go to those places, the easiest way to interview, to gather information about those places is to interview key informants that know about those places. It also allows the assurance that we will keep being able to do this data collection. Perhaps we could do a security assessment. One day we're able to go to that place, but the next time we want to do it, we can't. So by doing it remotely, we ensure that the data is regular. And then of course, this is less resource intensive. So we don't need to factor in these travel costs. A few things did work well. Specifically, we were able to triangulate and pull together the data quite easily, which we believe is quite accurate. So it's giving a good impression of what's happening, and we're able to capture this data very, very quickly. And we're able to cover a vast area. If we were out doing this data collection face-to-face, we wouldn't be able to go to so many locations. This then in turn allows us to monitor the situation. So we're providing outputs or relevant findings much more rapidly to decision makers in the context. Some of the challenges we faced are that we cannot verify these results. If we can't travel to the area, we can't know for sure that what the information we're gathering is accurate. Where we can triangulate results or pull in secondary data sources, this is a realistic way of verifying your results. It was also found to be quite challenging finding KIs that met a diverse range of perspectives and backgrounds. For instance, it was easy enough to find KIs to speak to from different geographical areas, but ensuring that we had a balance of men and women, young, older, and different vulnerable groups represented was more challenging. This just takes time to build up these networks and ensure that we're always prioritizing this when finding KIs. And then finally, another issue is that while a KI might be able to speak confidently about an area as a whole, it can then be quite difficult to capture inequalities or differences within that locality. So moving on to the next slide, we wanted to give you some tips and pointers specifically about the necessary steps required when planning a remote assessment, or in fact any assessment at all, actually. These are applicable to all. We won't have time to run through these in detail, but here you do have just a summary of the key steps required going from research design, establishing your assessment, all the way through piloting and launching your data collection, including enumerator training, ensuring that the data is monitored, tracked, and cleaned, making sure that it's analyzed accurately. This includes, if you're using remote data collection or qualitative methods, planning how you'll aggregate your results, and making sure that these findings are shared, are valuable, they make sense, and that they go into your programming and your planning. What you will find also when we share these slides is there are some annexed slides at the end that have this table broken down with quite a bit more detail. So you'll find some inputs and suggestions that are specifically designed for remote data collection assessments. So I hope that's more useful. And then of course, if anything is unclear, or you would like more advice, please do reach out. So then the next slide. Data protection. So this is, of course, very, very important at any given time, but we especially know the relevance of being careful with data protection when doing remote data collection. This is partly just because with the increasing use of technologies and also with the challenges of not being able to build trust face-to-face with your participants, it is ever more important. One thing we do recommend beyond these preliminary ideas to start thinking about data protection is that every organization should hopefully be able to develop some kind of internal SOP or procedure that will indicate how you will go about data protection specific to the data you're collecting. But as a few key starting points, we would just want to minimize the personal identifiable data that we are collecting. Quite often we think we need to know names and numbers, and sometimes we do, but actually very rarely do we need to say no names. So it's one thing to have a list of phone numbers, but it's different if you have a name and a number. They're suddenly a lot more identifiable and traceable. So just think about whether you need it. If you do, carry on, but make sure that there's very, very careful storage or sharing of this data. So on the second point, ideally only have one, maybe two people with access to the raw data. And then this can be shared, obviously, once it's been anonymized or cleaned beyond that. With these individuals that have access to this data, they should be personal and identifiable. So really, if you can assign who specifically will be having access to the data so that they can have accountability and ownership over the data, this can go a long way. And then finally, do delete data. Specifically, if you don't need personal data, say you wanted to collect GPS points to verify during data collection, but you're not actually going to use this beyond this point, do delete this, just so that nobody has it anyway. And if you really must keep data, do store it separately to the rest of the data. So you could reunite these key indicators if you need to at a later stage, but ideally in a password protected file. So then onto the next slide. So just as we're coming towards the end here, we just wanted to give you a few top tips for our key recommendations when going about remote data collection. Firstly, many of our do's focus on open communication. So do be explicit as you can, be as explicit as you can when you're doing enumerator trainings, or if you do have any interaction with participants. And also script the interviews as well as possible, including the introductions to the questionnaire and the conclusions, so that every enumerator is presenting the same type of message to participants. It's also good to try and foster interactive feedback mechanisms, both on your cleaning or on any complaints or feedback that participants might want to give. This can be sharing leaflets or that's much easier, obviously, when you can go to the field, but sharing leaflets or cards with your contact details, or if you're doing it remotely, including this into your scripting. So making sure at the beginning and the end of interviews, they know how they could follow up with an email address or a phone number, or any other way that you think could be relevant for the people that you'd be reaching out to. We also really want to do stringent and regular data cleaning. So throughout your data collection, you would want to be checking your data daily, or more often if you have the capacity to do that, so that you can get feedback in real time, and you can follow up and fix your data if you need to. You might also find that you're getting consistent errors, and there might be creative ways to fix this. For instance, you might find that a female respondent is not overly comfortable speaking to a male enumerator. So perhaps you can have a way to track this in your data collection trackers and have a female call up again to repeat the interview if you think this might give you more accurate results. As part of the do nots, we sort of focus on inconsistencies. So ideally, don't be inconsistent in your data collection approach. So don't start out with key informants using one tool, and then using that same tool, switch it to a household interview. You want your results to be comparable. So if you start out one way, try to see it through, or if you really find that that's not working, you might need to change your tool and relaunch your data collection, but don't compare these results. Do not overcomplicate questionnaires. It can be really tempting to try and collect anything that you think is relevant, but hopefully you'll have developed a detailed data analysis plan that's based on your information gap and your clear research questions. And so ultimately we'll be able to directly answer your questions with this very, very simple tool. Don't let outliers or odd results go unchecked. So it is really important that you follow up as soon as you can. And one of the frustrating things perhaps to think about is just do not expect total accuracy in the data. By doing remote data collection, more so than face-to-face data collection, it just is challenging to be able to verify the results or know if you're getting accurate responses. Don't be disheartened by this. You can just keep reviewing, keep applying logic to your data cleaning, and keep having lessons learned that will hopefully be applicable to any future rounds of data collection you might do. So then next slide. We're right at the end. I just wanted to conclude by saying that Reach does remain available. If you have any further questions or you would like to follow up more specifically, I know that the team taking over from me right now and the rest of this presentation will also make this a bit more specific to GBV. So as I say, this has been quite a general presentation on remote data collection at this time. Reach does also do provide direct support to different organizations on their data collection, whether it's remote or not. So if you would be interested in knowing how we can directly support you, please also do reach out. I think that is everything for me. We just have a last slide, and then as I said, please do check out the annexes if you think they'll be useful when these slides are shared. That's everything I have. I've been keeping an eye on some of the questions. I hope a few of them have been answered.
Great. Thank you so much, Peggy. I think you did give us a really good foundation of what GBV specialists and coordinators need to think about as we go about gathering information remotely. And I was really struck by one of those comments that we need to make sure we look at outliers or odd results to make sure that we check and recheck, so triangulate some of this data, which has really big implications, especially when we're talking about GBV. And then also I was really glad that you reinforced about security and then data privacy, which is another key issue when we talk about GBV data collection. So thank you. And I think Pam and Alexina are culling the questions from the chat. So we'll come back at the very end of the presentation, probably with some specific questions from them. But thank you so much. And we will have your presentation on our website, and then it also has your contact details. So thank you.
Great, thank you.
And I wanted to, just from the GBV AoR side, present some of our priority areas. And this is sort of the expectation that we have of coordinators and members of our GBV subcluster. We had a lot of questions about what do we prioritize, because I know it seems overwhelming. And so there are two key areas that we recommend that you prioritize going forward. Of course, these are not exclusive to other activities that are ongoing. But in terms of the COVID-19 response, these two areas really need your attention. And one of those is updating referral pathways to reflect the current availability of services. So whether you're working in a camp setting, camp-like setting, if you're on national level, sub-national level, please prioritize updating availability of services. So the things that we would like you to look at, and this, again, this list is not exhaustive, but do health clinics still have the capacity to treat survivors given the focus on COVID-19? Do MPHSS services being offered remotely? Or are they being integrated into existing health services? So these are all things you need to understand and know, and then disseminate to community members. And also, are there adequate protection materials or hand washing stations or other protocols put into place to protect healthcare workers, but then also to protect potential survivors who are seeking these services? We don't want to create another layer or another protection concern by just through the access of our services. Because again, we're reinforcing do no harm. Are safe houses still functioning and taking the necessary safety precautions? And I know many of our GBV service providers are funding safe houses. So we need to make sure that we're also providing additional support to make sure those safe houses have the necessary safety precautions. Are women-friendly spaces and child-friendly spaces still operational and adhering to strict safety protocols? And this is something even within our own teams that we are still kind of wrapping our head around, because in some country, women-friendly spaces and child-friendly spaces are not considered essential services. And then in other situations, we have some of our colleagues who have had the government list those as essential services. And this is something you're going to have to think critically about. We know that safe houses provide the stationary or protective, but women-friendly spaces and child-friendly spaces are often where psychosocial support services are offered. So again, looking at the entire context, we need to understand that. Also about cash transfers, the ability to still access cash, and then also other income generating activities, particularly since many of our affected populations or people within our purview, women and girls, vulnerable women and girls, depend very much on these income generating activities. So the first priority is that we check and update our referral pathways to include the new COVID-19 sort of ways of working. The second, and actually I should have put A and B because there's not necessarily an order to this. The second is we need to make sure that we assess the evolving protection risks of women and girls so that we can lead, or that this will eventually lead to more evidence-based programming. And this is where I think the REACH presentation really is causing a foundation. So many of you have been reaching out to us to say that you need to revise your work plans so that they include now COVID-19 specific activities. And so we really need to understand these new evolving protection risks. And so some of the things that we might want to think about, again, this is not an exhaustive list, but of course we'll always reinforce this, focus on assessing trends, not incident data. This is an emergency, and we will want you to fall back on the best practice that we know in emergencies. This is not the time for us to be doing comprehensive household level surveys necessarily. We have to think of who has access to phones and other things and looking at that. So we're really focusing again on trends. I think a dynamic to this crisis is also the breakdown of economic safety nets. We know that women are predominantly engaged to the informal workforce, and we know that because of this distancing and staying at home, this is crumbling. And so we need to understand that dynamic, because we know that often the most vulnerable have to resort to coping mechanisms for their very survival, what we sometimes refer to as negative coping mechanisms, which can lead to sexual violence, intra-partner violence, psychological violence. And so I think here in Kenya, the statistics are that 83% of the workforce is informal, and the majority of those are women. So just imagine the impact, really, and who's focusing on those most vulnerable. And I think that's in many cases us. So think about some of the tools that were provided, and then also think about how we understand what those evolving protection risks are at this point. So those are the two priorities that the GBV AoR recommends that we focus on at this point. We will be reaching out to our coordinators and working group leads to follow up on those two. But of course, others can reach out to us as well. I know we're running on time. I just wanted to provide a couple examples of how we've done this in other communities. So one thing we often overlook is the impact of the Red Cross societies. We do recommend that you look to Red Cross in your countries to see what their capacity is. And we've seen some success on this in other countries. For instance, volunteers led the community GBV assessments in Kenya during the drought, and continued to do health surveillance via mobile phones in inaccessible communities in Somalia. So these are volunteers who have already been trained. And so really reach out. And some I know in Burundi, they already have standby agreements with the Red Cross. They've already been trained on GBV programming and information collection. Assess anonymous hotline data to understand what the trends are. So for instance, the team in Zambia reviewed pre-crisis call data in drought-affected counties and compared it to current trends. And they were able to see a significant increase in the number of individuals, particularly men in this instance, reporting GBV in crisis-affected communities after the onset of the drought. And so if you have a hotline, I know that most hotlines usually do quarterly reports where they do publish anonymized data. So if you look back at what the call-in data, again, this isn't exclusive, but it's maybe one way to look at what the trends are in terms of reporting. As was mentioned by Peggy, obviously conduct key informant interviews with, all of us should have the contact details of our service providers. And so in order to update our referral pathway, it could just mean checking in with our counterparts who are doing service provision to understand how they've revised their programming due to the current crisis. And I know we have best practice from Ethiopia. One of our coordinators in one of the sub-regional zones had set up a WhatsApp group with service providers to encourage information sharing about service gaps because they also had limited access. But just to really clarify, they did not share information about specific cases. So among the service providers, they were more sharing information about equipment, essential drugs, what was available, not available, what they were seeing in terms of access. Some had said, we're not seeing so much because of movements of IDPs, these kind of things. And he was then able to really be a part of these discussions and quickly react. And then we have an example from the DRC that maybe wasn't the most successful, but again, we want to present what we know as examples. And this one was from the Kasai crisis. So OCHA led a MIRA assessment by phone with a methodology that was approved by the HCT. Informants identified GBV as a first priority, but then that priority was then sort of sidelined because the HCT refused to then accept the data, saying it was not valid. So make sure as well that the data you're collecting, and I think Peggy, you had mentioned this, is going to be valid across contexts. And I put a picture of this COVID-19, how to include marginalized and vulnerable people in risk communication and community engagement, because it's a really great resource that was created by IFRC, I think OCHA and WHO, that really gives you sort of a step-by-step, well, page-by-page introduction to some of these vulnerable populations at community level. And it really gives you really good recommendations and sort of food for thought about what you should be thinking about. So I didn't have a slide of vulnerable populations because I feel like you probably all know those based in your context. But really, if you can, we have it on our resource slide, do take a look at that resource because I think it gives you some good ideas about how to frame, for instance, persons with disabilities within the COVID-19. So different aspects to think about. It looks at GBV survivors, pregnant and lactating women, child-headed households. So I think it's a really good resource that I won't go over in depth here, but please do look at it. I think now I'm going to pass over to Leah Ashley, who will take us through the second part of this webinar, which is focusing on remote programming and then also remote service delivery. Leah Ashley?
Thank you so much, Jessica. It's such a pleasure to be here today. The main question for the second part of the webinar is how can you transition to remote service delivery? And we're going to start with a presentation by International Rescue Committee, IRC, and they will give us a perspective from their organization because they've gone through this process and evaluated it to determine some of the lessons learned, and they've also created some guidelines that we'll share at the end of this webinar. So over to you, Megan. Thank you so much for being with us today. Please do introduce yourself briefly and tell us where you're coming from, and we're excited to hear from you.
Great, thank you so much. Hi everyone, this is Megan O'Connor. I work with the Violence Prevention and Response Unit for IOC. We, I'm going to be presenting today on just a brief presentation. You don't hear us? You don't hear me well? I'm just seeing the chat. Is that better?
Yes, we can hear you now. Thank you.
Okay, sure. Just to start, a few years ago, IRC received funding from both ECHO and PRM to pilot and test both mobile service delivery and remote service delivery, GBV services. And the result of that process, of the 2-year process, the result of that was the development of guidelines, which I'll refer to later at the end of the presentation. That really—
Sorry, Megan, to interrupt, but can you please move closer to the mic again? We're having trouble hearing you.
Okay. Any better?
Yes, much better. Thank you so much.
Okay, I literally have my mouth like on my computer.
Thank you.
No worries, no worries. Just let me know if I need to move closer. Next slide, please. So I just wanted to start with some definitions because our guidelines do talk about both remote service delivery and mobile service delivery. So remote services are services that are provided over a technology platform. Usually that's a hotline, so telephone hotline, could be a chat or SMS over computer or phone, rather than in person. The guidelines we developed in 2018 mostly focus on mobile GBV services. And I just want to distinguish here that those are services where there are mobile teams with caseworkers that are moving to sites where a population is residing, or is in transit, or commonly located, and they can't be reached with a static service. And I'm just highlighting that here because I don't want there to be confusion about remote and mobile services. And also, I just want to be clear that with what we know about coronavirus transmission and what a mobile model requires, we would not recommend using a mobile approach. So I'm really just going to focus on remote services. Is this any better?
So we're still having a little trouble hearing you. If you can speak as close to the mic as possible, and we're also trying to work on our side to help on the tech end. But we can hear you, and it's very helpful to have the PowerPoint.
Okay, let me see. Is that any better?
That's perfect.
Okay, great. All right. Next slide, please. So what does a remote service look like? So it's an open access service so open access help that an individual can access either through phone or chats. We have caseworkers. Caseworkers need to be available via phone or chat during specific hours. And just really highlighting the nature of a remote service, that it is different than the kind of process of case management and psychosocial support that we can provide when we provide static services, for example, through a women and girls safe space. The nature of it being through a hotline or a chat is that it's short term. It really is focused on crisis intervention. And I would say primarily, within that, focused on safety planning and basic PSS. The other piece that I just want to highlight is that, you know, with GBV case management, we owe confidentiality is obviously primary, and normally, you know, a survivor would see the same caseworker, right? That's best practice. With hotlines, unless you can take a different approach, for the most part, you can't guarantee that, you know, a survivor calling is going to get the same caseworker based on schedules, based on when that person calls. Next slide, please. A few things that I just want to highlight about considerations as you may begin to think about whether you can switch to remote service delivery. So access is huge. It does require that the individual have not just access to a phone or a computer, but that access is safe and secure, right? So meaning that there isn't, especially in a situation of IPV, that, you know, there isn't somebody monitoring, you know, the phone or the computer or whatever that technology might be. The other thing I want to highlight about access is, you know, one of the ways in one of the contexts where we piloted this in Myanmar, one of the ways that we sort of got around the fact that, you know, women and girls often don't have that access to phones is that we had trained community focal points in the communities where we were working that we couldn't reach ourselves, and we provided them with phones. And so they acted really as kind of a hotline entry point for any women and girls who wanted to access the hotline. This obviously would need to be thought through very carefully, you know, given the COVID-19 situation. So then also I just want to talk about the limited services. I mentioned this earlier, but, you know, it's important that staff and clients, survivors, understand that it's not a full case management response that you can do on a, you know, with remote services. And the other thing that's important is, you know, just highlighting that referral options are likely to be limited and potentially need to be phone-based. So, you know, it was a great point that Jessica was raising about, you know, needing to remap services available based on COVID. And I think also with remote service delivery, you know, you also have to think about what are services that could also potentially be accessed through phone. Staffing and supervision. So it's really important to highlight that remote service delivery requires intensive training. You know, you can have your GBV casework team, you know, trained up and providing static services. And transitioning that team to remote service delivery does require further training for several reasons. They will need training on how to manage the technology that you're using. You'll have to develop and train on safety protocols, which are going to be different when you're using technology. As I mentioned before, it's an adapted service model. The other piece that's really important is that it does also require real-time technical support and supervision, so that caseworkers can actually troubleshoot in the moment, because we likely know that, you know, the survivor or person calling is not necessarily going to be able to call back again. And then lastly, just cost, I want to highlight too, with technology, but also staffing. So, you know, if you are if you're kind of trying to staff up a hotline, but also maintain other services, you can't really have the same people doing in-person services and hotline services. You need separate staff so that you can actually have the hotline available and have somebody able to respond and during the operating hours of the hotline. Next slide. Okay. So I just wanted to really direct you to some resources for further review that are in the guidelines, and I just wanted to kind of be specific since a bulk of the existing guidelines do focus on mobile approaches, which we're not recommending. So in terms of remote service delivery, in part 2 of the guidelines, page 27, you can find some guidance on carrying out an ICT assessment. In part 3 and in Annex 5, there's additional guidance for how you implement a telephone or other type of hotline. In part 5, there's a whole chapter. That whole part is about remote supervision and how you do that. And then lastly, I just want to highlight that one of the things that we developed through this project was an application called, an app called ROSA, Remote Offered Skill Building. And this was something we developed really to support remote supervision. So so on this ROSA app, you can download it onto phones or computers from Google Play or from iTunes. It's free. We have resources about GBV assessments. We have resources on GBV case management. So it's really intended to be a way for supervisors to to allow staff to kind of self-study. And so it could be something that is useful kind of in this context. And yes, people are providing the link to GBV responders. I assumed that that would be done afterwards, so I didn't provide it here, but that's where you can find the guidelines. Okay, thank you.
Thank you so much, Megan. That was extremely helpful. I've been taking lots of notes, and I hope we'll have time to get to some of those questions you have in the chat box at the end. I am conscious of time, so I'm going to move forward and remind everyone that the links for the guidelines that Megan just mentioned have been put in the chat box. So I really appreciate the points that you made that GBV service delivery done remotely is different. So we need to think carefully about what we should do to ensure we maintain the guiding principles when we're working in a different way. So please do look at the resources. I'm a fan of ROSA myself, and I encourage everyone to try to look at that resource and the other ones in the chat box. So moving forward, I'm going to build on that presentation to quickly look at how to prepare to move to remote delivery from an interagency or coordination perspective. So as a first step, GBV subclusters with protection clusters will need to prioritize understanding what the overall remote response needs and capacities are across multiple sectors of the GBV response. So subclusters or other coordination bodies. Can you hear me okay? Okay.
Yes, you're coming through.
Subclusters or other coordination bodies need to know what the different organizations and government capacities are for remote service delivery. So this means it goes beyond just case management, but also other services. So I'm going to suggest several options to do this, which are highlighted on the PowerPoint slide. So the first is looking at the traditional model of multi-sector initial rapid needs assessments, which Jessica also referenced, and integrating questions relevant to GBV services into those assessments, and of course always advocating for disaggregated data by sex, age, and disability. So this is one option. A second option could be a very short survey from the protection cluster, which asks partners what their current needs and capacities are for remote service delivery, as well as asking them what feedback they're receiving from beneficiaries. And we do have an example already from the protection cluster for the whole of Syria response, who has issued a COVID-specific 2-page survey to its members to get feedback in this way. So the advantage of these first two options is they're quick and they can be done with minimal preparation. For the third option, there could be a standalone assessment which is dedicated to a more in-depth look at what the remote service needs and capacities are. And the advantage of this approach is it allows a more detailed understanding of what specifically would need to be done to meet minimum standards in order to scale up a GBV response. For the more comprehensive assessment, it's good to combine secondary data review and use remote assessment methods to do public consultations and key informant interviews where possible. So thank you, Impact, for giving us more detailed guidance about how we might be able to do that. And we would recommend that these secondary data review and public consultations would be followed by key informant interviews by GBV Specialist. And the focus there would be to examine the different areas that IRC highlighted and really think about what the guidelines are for minimum standards. Just to note that the secondary data review components, as well as perhaps some of the remote surveys or focus group discussions, could be done jointly with other sectors or groups, such as communication with communities, as well as protection or gender and humanitarian action groups. So I'm going to stop there, but we are going to put a link to a draft template that the GBV AoR has developed for a more detailed assessment in the box. And this is a guidance note under development, and we welcome your comments and suggestions. It's just a starting point for those of you who may be working as a GBV coordinator and you need to think now about how you're going to assess the remote capacities for an overall GBV response. And I'll just, I'm not gonna work on that slide because I think IRC covered all of that information in their presentation, so thank you. I'm gonna end on a key message so we can go to questions, and that's just all of these suggestions are to spark innovative ideas for you as implementers to build on in the field. And I think we all need to continue to stress the needs-based approach, a human rights-based approach, and a community-based approach to this response, even though we're trying to learn new ways to implement those approaches. And the assessment and mapping of services that we talked today is the first start on that path. So I'm just going to remind everyone to have a look at this last slide about how you can keep informed and connected. We do have the GBV AoR community practice, and a big shout out to Sarah and Beth for all their help in disseminating the information about this webinar and about the resources that are available to GBV practitioners in the field. Please do contact Sarah at the address listed on the PowerPoint slide there, gbvcop@gmail.com. Also a reminder to please visit the GBV AoR website, where we're constantly updating information related to COVID and other aspects of GBV response. And both of those forums do have drop boxes and folders with the most recent materials on COVID. So with that, I know we're right at 4:30 and I want to move to questions for those of you who can stay online. Pamela and Alexina, could you please tell us 2 questions and then tell us who we should direct these questions to?
Okay, Alexina is trying to reconnect. So this is Pamela. We're trying to collate the questions and monitoring for commonalities. So for REACH, in terms of training of enumerators, can this be done remotely as well? Is there a possibility for a remote interview with language interpretation? That's for REACH. For IRC, for remote service delivery, are there other options aside from phone-related hotlines? If there's no access, no network, poor connection, the phone is controlled by the perpetrator, what else can be used? Training for remote safety planning. And then, does anyone have developed some training material for staff so that they can switch from the face-to-face to remote service delivery?
Okay, let's start with REACH.
Yes. So two questions about training enumerators or using interpreters remotely, I think were the ones for me. So yes, we do have experience using both. Interpreters, less commonly. What we would ideally do in this instance is we would have somebody in the local language or relevant language conducting the interview firstly by phone, and then another staff who would want to say translate or interpret would sit with them, ideally observe, and then after the interview completed debriefing form. So you would capture the nuances and follow up on anything that didn't come correctly. So one of the most effective ways to do this is to do your translation together immediately after the interview. So this can be quite time consuming, but there's different creative ways to play around with it. Or alternatively, if you have the capacity to have a speaker on the phone that you're conducting the interview, just have both you or whoever's doing the interview and an interpreter both there conducting it together. For training enumerators, it certainly is more useful to do an enumerator training face-to-face. There's no doubt about this, just because of the face-to-face interaction you get as well, and the fact that you can follow up with questions and gauge better how well people are absorbing what you're telling them or see if there's any confusion. However, we often do our data collection trainings remotely. Part of in a lot of the countries that REACH is working in, we do a multi-cluster needs assessment that's usually nationwide, and we often work with partners who sometimes can't come in to do the training with us. And what we do is we make sure we have very, very thorough training materials, such as presentations, and have them translated into all relevant languages. And we always conduct the training via Skype or occasionally by phone call if really necessary. And we always do a follow-up once we've given at least a day of thinking time, checking in again to see if they have any questions. And then in these cases, we pay extra close attention to the data that's coming in, doing daily data cleaning and following up by phone as needed for any other issues.
Thank you. Again, I'm taking notes copiously here. Those were excellent suggestions. And Megan, could I ask you to address the questions regarding other options for besides mobile phones and training options?
Yeah, sure. I mean, to be totally honest, I don't have an answer to the other options besides mobile phones. I mean, that sort of remote service delivery is really contingent on that. I did see a comment from one of the participants about shielded sites or hidden apps, so that if people have a family phone and not an individual one, you know, IPV survivors could potentially still access that technology safely. So there might be some creative ways to, you know, to think about that and like kind of the type of chat app that's used. But I really don't have a good alternative. To remote service delivery really rests on using technology. If I think of something, I will certainly reach out. And maybe other folks have ideas on the call. In terms of training materials, we did develop training materials for our staff. They're currently not public. In other words, we don't have them on our website on GBV responders, but I can potentially look at sharing them out with this group if that would be helpful.
That's really appreciated, Megan. And also, I think it's okay to say that we don't all have the answers right now. This is a moving target, and we're all looking for ways to be innovative. So thank you for being honest. And I think these are the kind of conversations that we can continue on the community of practice, where we all contribute ideas or innovations that we encounter in the field. And any guidance, including training materials, is much appreciated. And I think we all have such an opportunity to learn from and collaborate with each other during this response. So thank you. All right, I'm conscious that we're a few minutes over time. Just to let you know, we are collecting all of the questions in the chat box. Unfortunately, we're not able to cover all of them today, but we will collect them and try to respond as best we can through the material in our future webinars, as well as through the GBV AoR website and community of practice forums. And please do always feel free to reach out through those forums to us as the Regional Emergency GBV Advisors and the GBV AoR team. So thank you to everyone. That's all our time for this week. Please stay safe, stay well, and keep saving lives. And we look forward to seeing you at the same time next week. We'll send out the invite through the Community of Practice and GBV AoR and keep you updated. Thank you.